Peritonitis, acute abdomen. Definition: peritonitis is an inflammation of the peritoneum, the tissue that lines the inner wall of the abdomen and covers and supports most of abdominal organs. Peritonitis is usually caused by infection from bacteria or fungi. Peritonitis is the inflammation of the peritoneum, the serous membrane lining the abdominal cavity and covering the viscera. Causes and types. The two main types of peritonitis are: 1. Primary spontaneous peritonitis, an infection that develops in the peritoneum. The most common risk factors for primary spontaneous peritonitis include liver disease with cirrhosis. Such disease often causes a buildup of abdominal fluid, ascites, that can become infected. Kidney failure getting peritoneal dialysis. This technique, which involves the implantation of a catheter into the peritoneum, is used to remove waste products in the blood of people with kidney failure. It's linked to a higher risk of peritonitis due to accidental contamination of the peritoneum by way of the catheter. 2. Secondary peritonitis, which usually develops when an injury or infection in the abdominal cavity allows infectious organisms into the peritoneum. Common causes of secondary peritonitis include a ruptured appendix, diverticulum, or stomach ulcer. Digestive diseases such as Crohn's disease and diverticulitis. Pancreatitis. Pelvic inflammatory disease. Perforations of the bowel, stomach, intestine, gallbladder, or appendix. Surgery. Trauma to the abdomen, such as an injury from a knife or gunshot wound. Non-infectious causes of peritonitis include irritants such as bile, blood, or foreign substances in the abdomen, such as barium. Both types of peritonitis are life-threatening. The death rate from peritonitis depends on many factors, but can be as high as 40% in those who also have cirrhosis. As many as 10% may die from secondary peritonitis. Pathophysiology. The pathophysiology of peritonitis involves leakage. Peritonitis is caused by leakage of contents from abdominal organs into the abdominal cavity. Proliferation. Bacterial proliferation occurs. Inflammation and edema. Inflammation and edema of the tissues occurs, and exudation of fluid develops in a short time. Invasion. Fluid in the peritoneal cavity becomes turbid with increasing amounts of protein, white blood cells, cellular debris, and blood. Response. The immediate response of the intestinal tract is hypermotility, soon followed by paralytic ileus with an accumulation of air and fluid in the bowel. Clinical manifestation. The first symptoms of peritonitis are typically poor appetite and nausea and a dull abdominal act that quickly turns into persistent, severe abdominal pain, which is worsened by any movement. Other signs and symptoms related to peritonitis may include abdominal tenderness or distension, chills, fever, fluid in the abdomen, not passing any urine, or passing significantly less urine than usual, difficulty passing gas or having a bowel movement, vomiting. Assessment and diagnostic findings. Assessing and diagnosing peritonitis involves the following: history taking, physical examination, increased WBC. The white blood cell count is almost always elevated. Serum electrolyte studies. Serum electrolyte studies may reveal altered levels of potassium, sodium, and chloride. Abdominal X-ray. An abdominal X-ray may show air and fluid levels as well as distended bowel loops. Abdominal ultrasound. Abdominal ultrasound may reveal abscesses and fluid collections. CT scan. A CT scan of the abdomen may reveal abscess formation. MRI. MRI may be used for diagnosis of intra-abdominal abscesses. Culture of peritoneal fluid may show bacteria. Peritoneal fluid analysis may show cloudy appearance, increased WBC count, pus cells presence, blood cells, cell debrides. Medical management. Fluid, colloid, and electrolyte replacement is the major focus of medical management. Fluid. The administration of several liters of an isotonic solution is prescribed, e.g. NS, D5RL. Analgesics. Analgesics are prescribed for pain, e.g. tramadol, morphine, diclofenac sodium. Intubation and suction. Intestinal intubation and suction assist in relieving abdominal distension and in promoting intestinal function. Oxygen therapy. Oxygen therapy by nasal cannula or mask generally promotes adequate oxygenation. Antibiotic therapy. Antibiotic therapy is initiated early in the treatment of peritonitis. Surgical management. Surgical objectives include removing the infected material and correcting the cause. Excision. Surgical treatment is directed towards excision, especially if the appendix is involved. Resection. Resection of the intestines may be done with or without anastomosis. Fecal diversion. A fecal diversion may need to be created with extensive sepsis. Nursing management. Nursing assessment. Assessment should be ongoing and precise. Pain. Pain should be assessed continuously and should be acted upon. GI function. GI function should be monitored to assess response to interventions. Fluid and electrolyte. F&E should be balanced. Nursing diagnosis. Based on assessment data, the diagnosis appropriate for the patient are: acute pain related to peritoneal irritation, deficient fluid volume related to massive shifting of fluids towards the intestinal lumen and depletion in the vascular space, risk for shock related to septicemia or hypovolemia, risk for infection, risk for imbalanced nutrition, less than body requirements, anxiety, fear, deficient knowledge, nursing care planning and goals, reduce level of pain, restore fluid and electrolyte balance, prevent complications, restore normal GI functions, nursing interventions. Blood pressure monitoring. The patient's blood pressure is monitored by arterial line if shock is present. Medications. Administration of analgesic and antiemetics can be done as prescribed. Pain management. Analgesics and positioning could help in decreasing pain. I&O monitoring. Accurate recording of all intake and output could help in the assessment of fluid replacement. For fluids, the nurse administers and closely monitors for fluids. Drainage monitoring. The nurse must monitor and record the character of the drainage postoperatively. Evaluation. Reduced level of pain. Restored fluid and electrolyte balance. Prevented complications. Restored normal GI functions. Complications. The abdominal cavity shows widespread infection that can lead to complications. Sepsis. Sepsis is the major cause of death from peritonitis. Shock. Shock may result from septicemia or hypovolemia. Intestinal obstruction. The inflammatory process may cause intestinal obstruction, primarily from the development of bowel adhesions.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.